What is the most damaging myth, in your opinion, that you think fit women have absorbed about their pelvic floor as they age?
It's the leaking. And so there's a myth around leaking is normal, leaking is just part of aging, leaking is what happens after you have babies.
All right, so let's just dive right in. Kim Vopni, thank you so much for being on this podcast.
Thank you for inviting me on the podcast.
You're a kind of a niche coach, but the overlap with what I do, what my team does, is enormous, and it's so important, especially as we age. And honestly, I got schooled in that myself, hitting my mid 50s now. I'm 55. I've been in menopause for a couple of years now, and going through GSM, right? So it's been like, wow, okay, this thing, shouldn't we have heard more about it? So I want to dive in and just pick your brain. I think you've got so much great information out there. We can dispel a lot of myths, and I know that's important for you, and keeping things evidence-based for women so that I want them to leave this call feeling empowered, that they have a lot of tools, a lot of resources around maintaining pelvic floor health, how to train hard, how to avoid or deal with incontinence, which is something that, of course, is circulating as we get older, that fear of, will I be that woman that sneezes or jumps or can't run anymore because of that incontinence? Is there anything that I can do for that? Mm-hmm. So let's go and disrupt some outdated narratives. What is the most damaging myth, in your opinion, that you think fit women have absorbed about their pelvic floor as they age?
Well, sort of, I guess, expanding on what you just said, and you used the word incontinence. And incontinence is one form of pelvic floor dysfunction. We hear about stress urinary incontinence because that's what the pad companies are marketing to us for.
Okay.
It's the leaking. And so there's a myth around leaking is normal, leaking is just part of aging, leaking is what happens after you have babies. So there's the myth of it's just normal, but also the myth of incontinence is the only pelvic floor challenge that women face. So there's a lot of other challenges that are associated with pelvic floor dysfunction that women they've never even heard about. So we hear about incontinence, but it's actually less common than some of the other conditions like pelvic pain or pelvic organ prolapse that women also face.
Love that. So can I say that waiting for incontinence, is it kind of later stage, or is it just like lateral? It's just different on a horizontal scheme of things versus it's a tertiary thing. Like, do you know what I mean?
You mean like, is incontinence the one that comes first between all of the types?
No, it's the one that comes last.
Oh, not necessarily. We have young people dealing with incontinence. It's happening younger and younger. So it's always been associated with, it's going to be when I'm approaching nursing home age or when I hit menopause. It's for older people that get incontinence. But anybody, even men, I mean, we're going to focus on women here, but anybody can deal with incontinence. And sometimes it is the first, I would say, but it could also be part of other things that are going on that we don't necessarily associate being related to one another. So somebody might have incontinence and pelvic organ prolapse. They might have pelvic pain and incontinence. So I wouldn't say that there's necessarily a step-by-step, this comes first, this comes second. There's many different ways that it can present, and it can present at many different stages of life.
Great. So issues around pelvic floor health can present themselves differently. It's not always what we commonly associate it with, which is the incontinence. There are other things that can signal that there are pelvic floor health issues. Correct?
Correct. Yeah. Okay. A big one actually that I want to highlight is back pain.
Yeah, thank you.
Over 95% of women with low back pain have some form of pelvic floor dysfunction. Could be incontinence, could be pelvic pain, could be pelvic organ prolapse. But we chase back pain with, we go to the chiropractor, we go to the massage therapist, we do acupuncture, we go to physio, which are all great and can absolutely play a role. But so often the missing link there is the pelvic floor.
Love that. Let's dive in. Let's dive into what the pelvic floor is, right? So I've heard it said that the pelvic floor is a system. It's not about Kegels. There's this idea of timing, of breath. Can you dive into that a little bit for the audience? I'm here to learn too. I'm going to be honest. This is all very exciting, relatively new things. Like really going deeper into what great pelvic floor health could be for us.
Yeah, and deeper is a good word. So deeper into the pelvic floor is the foundation of our core. So you are a movement professional. You are in the fitness industry. You talk about core. We learned about every single muscle in the body, origin, insertion, function, all the things. But did we ever learn about the pelvic floor? Nope. It is not in any fitness training. Never. So the pelvic floor is, like the rest of the body, it's muscle. It's several muscles, several layers of muscles, ligaments, tendons, nerves, blood supply. And the principles of muscle, so how we build muscle, how we lengthen muscle, how we release tension, apply to the bicep, to the quadricep, to the pelvic floor. So the pelvic floor is this group of muscles, 3 different layers of muscles that close off the opening or the base of our pelvis. So if you think about, if you put your fingers on your pubic joint at the front, you put your fingers on your tailbone at the back, you find those 2 bony points under your, through your butt cheeks, the sits bones. Those 4 points are where the pelvic floor muscles attach. And so they close off the base of the pelvis. They are the foundation of the core. When you think of the word system, the pelvic floor, you could argue maybe is a system, but it's part of the deep core system. And it needs to work in synergy with our diaphragm, with our transversus abdominis, the deepest abdominal layer, the multifidus, which are spinal stability muscles. I call that unit the core 4. The diaphragm, pelvic floor, transversus, multifidus is the core 4. It needs to work. They all need to work together for core stability, organ support, continence, sexual response. And also there's like a sump pump action between this movement of the diaphragm and the pelvic floor that helps with blood flow, circulation, moving lymph through the body. And we see other muscles in the body. We can go to the mirror and we can flex our bicep. We can see our legs. We can see everything. The pelvic floor is inside. We can see our external genitalia, but we don't see the muscular structure per se. We don't know that there's layers. We don't know that there's multiple muscles. We don't know that because nobody's ever told us. We don't know this because nobody's ever explained it to us. And it's typically not until we experience some form of pelvic floor dysfunction that all of a sudden we start to learn about it because we have to. And then we think, well, why didn't anybody tell me about this before? And especially being in the fitness industry, it honestly shocks me. And I think it's irresponsible that none of the trainings, the certifications that people take to learn about the body, who are then going to go on to train predominantly female clients, they don't know anything about the pelvic floor. It's a hugely missed opportunity.
This is where you come in, right? This is probably part of your mission, especially like I know you're incredibly active and fit, and I'm sure you get a ton of women that are into fitness as well, and you see that this is just something that has to shift. And I think we're in a really interesting time in social media and legislation and fitness, particularly well-being, where we're seeing a clamoring, for good and for bad, of addressing female-specific issues, right?
Yes. Yes.
So we know that the pelvic floor is, well, according to you, but I absolutely agree with you. When I think of myself, how I've evolved embracing and how it has changed how I breathe and all of that, absolutely. It's so vital to the core. We can't see it. We're lagging in terms of our understanding of it. What can a woman listening to this podcast now do in terms of some small steps? Where could she go to find more information about this? So that, because, one of the things that we want to do is, it's important, but let's not overcomplicate it, and let's not create a bunch of fear around it, right? Let's not gatekeep. Can you speak on that, please?
Yeah.
So throw us a bone.
Yeah. I totally agree. We don't want to, we like leading with fear happens so much in social media.
Especially for women.
Yeah.
And then you get sold something.
Yeah, we need to highlight what can go wrong and why things are going wrong, but we don't always explain the other piece of it. So in terms of what people can do, The number one thing, if people take only one thing away from this episode, it would be to find a pelvic floor physical therapist in your neck of the woods and go see them. Go have an assessment. So part of the message is get informed. Part of the message is also don't wait until you have symptoms. We are very reactive as a species. We wait, and then once we have a problem, we'll go and fix it. But preventatively, we don't think so much. Maybe you do. I know I do, but we don't always think about preventing the onset of incontinence or GSM, partly because we don't know how to do it. We don't know why it's happening in the first place. So getting informed about what the pelvic floor is, the jobs that it has. So I mentioned sexual response, organ support, continence, core control and stability, sump pump, like really, really important jobs. So we have to understand why it's important. We also want to understand the links to other aspects of health. 46% of women from research stop exercising because of their pelvic floor. And most of those are actually in the younger age. And if we think about part of our mission of helping women age powerfully and the transformation you've seen with your mom, in order to do that, we need to have a strong pelvic floor. We need to be able to move. We need to be able to load. We need to be able to lift and do all the things. So without the knowledge of how the pelvic floor works and what we can do to strengthen it beyond Kegels, then if we don't have that knowledge, then we will be limited. Potentially, we might choose to stop moving. Potentially, we might have to stop moving. Potentially, we might just avoid certain movements, and therefore we're not creating as much resilience. So see a pelvic floor physical therapist, get informed, understand the status of your pelvic floor. Understand if your organs are in the appropriate anatomical position. Can you contract and relax? The pelvic floor isn't just there to squeeze. It needs to engage, have a closure, have a lift, and it has to let go. We've interpreted a pelvic floor exercise as just squeezing. So understanding the nuances of how the pelvic floor works, that there is a range of motion, that there are multiple ways to exercise the pelvic floor, and that principles of muscle, I mentioned strength, endurance, power, lengthening, all apply to the pelvic floor as well, not just all the other muscles, and then we just do Kegels for the pelvic floor.
Say somebody doesn't have access to that. They're living in a state or a province. They can't get to a pelvic floor specialist, or the lineup is enormous, which I'm saying that's going to be happening with, again, where social media is going in this sudden awareness and then the burgeoning aging population, and coupled with women wanting to get fit now and lift heavy. So say they can't do that. What is there something that they can do, a resource that they can go to where they can at least kind of self-assess? Do I have an issue that, like, come hell or high water, I do need to go and travel and get help? Versus, you know what, things are actually like, okay, I don't do this, I don't do that, this doesn't happen, I can do this. Is there anything like that that's available to women?
I can direct you to some of my stuff, but I don't want this to be about self-promotion. I'm going to give you some things that people can just do on their own.
Self-promotion. We want to get good information out there.
Yeah,
Kim. Fire
I
away.
have a book. I have a YouTube channel. Like, people can go and get information there. But here's a few things that can highlight if you have a problem. So if you are waking up multiple times a night to pee, if you wake up
and you're not in contest prep and your coach is making you drink 5 liters of water a day, I want to just caveat that.
Right. Okay. If you have huge volumes of water, that's going to change. But generally speaking, you should not be waking up at night. If you had a huge volume of water before, or something else to drink, or you had a bladder irritant, you had alcohol, you had caffeine late in the day, you're probably going to have to wake up. But disrupting your sleep is also going to be disrupting your pelvic health, not to mention all the other aspects of your health. So waking up, if you're waking up at all, I mean, you're going to wake up, but if you wake up and go to the bathroom and then you wake up again, you go to the bathroom and you wake up again, you go to the bathroom, that is not normal. That's a sign that your pelvic floor is asking for some help. Another sign is leaking. So if you leak when you laugh, cough, sneeze, jump, lift, bounce, trampolines, running, that is a sign. Not to say that any of those things are bad. It's to say your pelvic floor is saying, I can't manage this currently. I need some help. If you are running urgently to the bathroom, so you might be fine, and then out of the blue, maybe you hear water running, maybe you look at a bathroom, maybe you're coming home at the end of the day and you put your key in the door and all of a sudden your bladder starts like alarm bells and you have to race to the bathroom. That is not normal. That is a sign that your pelvic floor is asking for some help. That's urgency. If you leak, in addition to that, it would be urge incontinence. Some people say, oh, I have a small bladder. I'm always going to the bathroom. I have to find a bathroom every 20 minutes, half an hour. That's not normal. Very, 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 very rarely would anybody actually have an anatomically too small of a bladder. And that's often a trained behavior. So people that go pee just in case, people that avoid drinking water, people that are constipated, people that are low estrogen, people that have like high inflammation, all of those can be reasons why your bladder is signaling you more often than it should. Bladder irritants is another thing. So if you feel like you're always going to the bathroom, you're going more than the normal range of 5 to 9 times in a day, that would be another sign that you would benefit from some help. Anal incontinence, so leaking gas or stool, also not normal. Pelvic pain, pubic joint pain, tailbone pain, painful intercourse. And that could be pain like burning. There's maybe some bleeding. It feels like sandpaper. It could also be pain from feeling like you can't insert anything, feeling like the door is closed, or pain like you feel like if there's something being inserted, it hits something, like there's something in the way. That could be an indicator of tight muscles. It could be an indicator of pelvic organ prolapse. Heaviness and pressure, especially as the day goes on. Some people might see or feel a bulge at the opening of the vagina. Again, I mentioned back pain. Back pain is very common. So those are all signs that your pelvic floor is needing a little bit of TLC. And some people will then say, well, how do I know if I have, do I have a strong pelvic floor or do I have a weak pelvic floor? And I think we can't be so black and white with that. Somebody can have, we interpret strong as tight. And so we think about, well, I better tighten my vagina and then my organs aren't going to shift, or then I won't leak, or then I will feel intercourse better, or it'll be better for my partner. We associate tight with strong. Tight is weak. Tight muscles have poor blood flow circulation. They don't go through a good range of motion. They feel achy. What we want is a balance of tone. We want the ability of the muscles to react at the right time and generate enough force, but then be able to let that go. So having somebody help you, in person, if you can, help you determine if you have tension is ideal. But if you leak, if you have pain, if you have urgency, if you feel bulges, all of those could be because of tension. So even constipation can be because of tension. So it's a little bit nuanced in there. And generally when people come in and start I have 28-day challenges and programs that introduce people. If their symptoms are getting worse with the protocol that I have, that's a really good indicator that they have excess tension. That's part of the challenge. So then we back up how much voluntary activation we would be doing, and we focus a little bit more on releasing tension. So those are some things that people can just start to notice, and then they could use something called like a bladder diary, and they could track how much water they drink, how often they go to the bathroom, if they have any urges, if certain foods are more irritating to them, if certain activities make them go to the bathroom more often or leak or, have any of the other symptoms. So that's another tool that could be helpful if they don't have access to working with somebody in person.
So if I heard correctly, I think incontinence of some sort is probably the most obvious sign that there's something going on. And so if I was in a backwaters and I was having that in some shape or form, that would probably put, I wouldn't want to escalate that and let's make an effort. Let's go and find someone and travel if necessary and go get assessed. Now, if we're falling into some of the other categories that we haven't, most of us, including myself, have associated with pelvic floor dysfunction, like back pain, frequent urination, flatulence, for example. Did I miss anything? Is there any other one of those kind of more ambiguous symptoms that we want to be alert to that could be also a reason why we would want to explore more urgently, especially when we're younger? So when I say younger, I mean 50, right? Versus waiting until you're my mom's age, and she definitely has issues. You know what I mean? Yeah.
Yep. Yeah. Yeah. I guess I want to paint the picture that in an ideal world, pelvic floor physical therapy is like the gold standard, most underused women's health resource we have. However, I understand geographically not accessible for everybody, financially, maybe not accessible for everybody. Maybe there's people who don't necessarily want to have an internal evaluation. And that's totally fine. And that doesn't mean that you can't address incontinence, you can't address prolapse, you can't address pelvic pain when you have the right education, but you just need to be able to get the right education as a first step. So I would say education first, then if you can build in, just like we go to the dentist once or twice a year for our teeth, and we go even if we don't have a toothache, I think we should be doing the same for the pelvic floor, but it's not part of our culture yet. So until we get there, we can use social media. There's many YouTube channels. There's an incredible number of pelvic health professionals on social media. Get informed, find somebody who resonates with you. There's books about the topic, and learn. And the other thing I guess I want to highlight is part of my mission, I guess, yes, I want to educate people about pelvic health, but I don't want this to be, it's another thing on the to-do list, right? We can incorporate this into
that's where my mind goes as a coach. It's like,
doing.
And I want you to do this too.
Right. Yeah, we already have a lot to do. And we think about, oh my gosh, I need to have to all these things. And especially as we get older, we have even more things that we have to address because we have these.
I know we've all seen those reels with the mid-50 woman that has to do all these things and take all these things just to get at the door. And it's like, honestly, I don't do any of those things. Do we really need to? And let's address things as they come up. So if we go back to symptoms that might indicate other than incontinence, which is so obvious that we should escalate and, really go and get an assessment or at least take a course if it's virtual with somebody, like just up the ante a little bit. What would those be besides back pain, flatulence, frequent urination? What are some other of those sort of atypical for us, for the laywoman, atypical symptoms that we might have an issue?
Right.
A painful intercourse.
Some people think incontinence is just leaking. And if you have any other, like maybe urinary retention, like you have a hard time, you sit down to pee and you feel like you have to pee and then you sit down and you're like, come on. And you feel like you need to push to get it out. That could be another symptom that people maybe don't associate. So overall bladder, like urinary health, is not just incontinence, meaning the leaking. It could be the sudden overwhelming urges. It could be triggers, like it's like a Pavlov's dog response. It could be the peeing just in case. It could be, people who plan their day around their bladder, just looking at how they go throughout their day. Maybe they're wearing pads just in case. Maybe they have an extra set of underwear. All these compensatory strategies because we're afraid of leaking, because we're afraid of urges. So that's one. The frequency, as I mentioned, like they feel they always have to go. Painful touch. So that could be if clothing hurts, anything touching your vulva is uncomfortable. If you have burning, itching, irritation, if you feel like some people say they feel like there's something inside the vagina, even though there's nothing there. Those can be a couple of other symptoms that people may not associate with that.
Beautiful. And then do you put GSM into genital symptoms of menopause? Do you lump that into pelvic floor health?
1000%. When I started this work, I was in the prenatal postpartum phase of my life. And that's where I grew up with this sort of fear, but fascination with pregnancy and birth. And I grew up thinking, I'm never having children. And then because I witnessed the challenges that my mom had. That was my whole thing. And then I meet my now husband. We decide we want to start a family. I'm determined to have a different story. I use a product from Germany called the Epino, which is a biofeedback device for the pelvic floor. I'd never heard the term pelvic floor before. All I knew was this, I just didn't want to tear. And that's what this device was designed to do. So that's the world that I worked in when I first started. I recognized that we know pregnancy and childbirth are one of the highest contributing factors to pelvic floor dysfunction. Why are we not educating people about the pelvic floor before? Why are we not helping them birth better? Why are we not helping support them postpartum? So that was my initial mission. Then it was trying to optimize postpartum recovery a little bit more, using principles from other places in the world. And then I started going through perimenopause and I was like, oh, well, here's this whole other chapter of life and learning about menopause and all the other things. And at the time when I was going through that, I didn't know the term perimenopause. The term GSM wasn't even created yet. So I just witnessed this as, this isn't just a do your Kegels in pregnancy and here's how you can recover better. And then and then you're done with the pelvic floor. This is something we need to be aware of through our life. And our pelvic floor evolves as we evolve. So genitourinary syndrome of menopause, that term has been around for maybe like 7, 8, 9, somewhere in the 7 to 10 years. When I was going through perimenopause, it was just before that, and the term was vaginal atrophy. And so again, we sort of just associated that, oh, that's what happens when you're like way past menopause. So because of my own journey, but also recognizing that the majority of people that I support are in that phase of life, I needed to get more educated about menopause. And what has happened because of this explosion in the conversation of menopause is it's actually indirectly fueled the conversation around pelvic health because of genitourinary syndrome of menopause, GSM for short. That replaces the old, outdated, not very accurate term of vaginal atrophy. Atrophy is one element of GSM, but it really encompasses, though, all the forms of pelvic floor dysfunction. So there's genital changes to the structures, to the external genitalia, dry, thin tissue that can create discomfort, itching, burning, sometimes bleeding. Then we have urinary symptoms. So all of the incontinence, waking up at night to pee, prolapse, urgency, that's under that bucket. And then we have the sexual symptoms, signs and symptoms. That can be difficulty with insertion, painful sex, sandpaper sex, not wanting to have sex. So indirectly, GSM is highlighting a lot and unveiling a lot about pelvic floor health, but women are learning about it when they have to learn about their hormones, when they have to learn about menopause, when they, so it becomes another like, oh my gosh, I have to have this whole other thing happening now too.
Well, I know we exchanged briefly, I think on socials, and it was around, I think I'd asked you, I'm not sure how it came out, but I was, for me, I'm a huge fan of the suppository, right? Which we know is not the same as systemic hormone therapy. I don't hear that surfacing a lot amongst my clients. I would definitely say in our ecosystem, we are seeing a lot of women very influenced by influencers talking about the non-proven benefits of systemic hormone therapy. And I'm like, but what about GSM? And, because listening to experts, you want to be on top of that. There are some things that you can't reverse without when the tissue starts to go. So there's always all that strange piece. And what would you say about that in terms of the people that you're seeing, and when would be a good time to investigate whether that would be an option for you? Is it when you see signs and symptoms?
Yeah. So vaginal estrogen, in my opinion, based on the overwhelming evidence, is essential for all women from the start of menopause for the rest of their life, or sooner if they have symptoms. Postpartum, they will often have similar symptoms. A new term was also now coined, genitourinary syndrome of lactation. The two mirror one another because it's a low estrogen state. The difference is after you've given birth, typically, unless you are approaching menopause when that's happening, you are coming out of it and you get back to the normal ebbs and flows of estrogen. When we are post-menopause, we have had this decline, sort of falls off the cliff, and then it never comes back unless we are replacing it. So estrogen is, again, in my opinion, essential. It's something we would use for the rest of our life. Don't wait until you have the symptoms. We know from research, upwards of a little over 80% of women will experience one or more signs of GSM. Don't wait until, right, it's incredibly common. And usually it has been building. There have been things along the way for most people that they're just choosing to ignore, or they've been told, oh, it's just part of aging. They've just accepted it. And then when the estrogen piece is now in there where it falls off the cliff, now it just either makes pelvic floor symptoms show up for the first time or makes the existing ones show up even worse. And then they're like, okay, now I really have to take action.
Like, don't you get a bit frustrated when everything that has urgency around female health seems to orient itself around sex? And it's like, I think this is your health. It's your body. I love the female body, and I love doing my part to change the narrative around what aging powerfully actually could be for women. And this idea that, no, it's your body. You're in your body. And the things that we assume are normal as we age don't have to be your story anymore. But there are things that we can do from a pharmacological standpoint, or technology, or learning how to breathe, what good posture is, like relearning how to run our rig. I call our body our rig, like how to really run our rig, get a better blueprint on it, and change the story of what it means to be in an older female body, so that your kids, when they look at what it means to be 70 years old, they're not picturing, the back, the extreme kyphosis, the pads, not being able to do dynamic movement. Like, it doesn't have to be like that, but we do want to get in there early in an empowered way, not in a fearful way.
Yeah. And estrogen is, it's a part of what helps us with blood flow. It's a part of what helps us with circulation. It's a part of what helps us avoid UTIs, which become very common post-menopause. It's also, in a recent piece of research, they looked at people, they used the term vulvovaginal atrophy. So it wasn't the most updated term of GSM. They had VVA as the terminology, but they had a group of women with VVA. They gave one group Kegels, so pelvic floor muscle exercise, and the other group had Kegels plus vaginal estrogen. The group with Kegels plus vaginal estrogen fared better. And that makes sense to me because, one, we have the tissue support. The exercise is helping with the blood flow and circulation. It's helping deliver the estrogen. We're also getting the benefits of doing the exercise. Anybody who follows you appreciates what exercise can do. Those same principles apply to the pelvic floor. When we learn how to connect with it, we learn how to activate and relax it, progressively load it, train it for power, do all the same things, we can not only overcome our symptoms, but we can now create a much stronger base that reduces our risks of falling, that reduces our risks of needing to be admitted to a nursing home. It is one of the leading reasons why elderly women are admitted to nursing homes, because the family is like, I can do everything else, but as soon as I can't manage the continence, I'm out, and we go. So if we look at things like fall risk, that's huge. And a lot of people are falling because they're waking up multiple times a night to pee in the dark. They don't have good hip strength.
That's a good point. That's a good point, Kim.
So when we can establish a really good, strong foundation, all of a sudden we can do more. We can stay more active. We can move in more varied, dynamic ways, which only helps us age powerfully, only helps build the resilience and the capacity, rather than, I'm afraid of exercise because I'm going to leak. That might make my prolapse worse. Or being told by a care provider, you can't lift anything over 10 pounds because you have a prolapse. I don't agree with that. We need to respect some boundaries in there, but we need to come back and we need to treat the pelvic floor as something that can be strengthened with multiple different approaches, like we do all the other muscles in our body, rather than saying, you're just going to have to sit on the couch because we need to protect the pelvic floor. And therefore, you're then going to get diabetes and heart disease.
Yeah, I want to dive into strength training as well. So I think, just to sum up quickly, in your opinion, women that are entering perimenopause, based on stats, with 80% of women going through the menopause transition experiencing some degree of GSM, and we know that vaginal estrogen is something that can really impact that trajectory. That's something that women should be really investigating and talking about with their doctors. Is that true for me to say that?
Yes, 1000%. Dr. Rachel Rubin, Dr. Kelly Casperson. I would go to YouTube and put in July 17 FDA menopause. There was a whole panel of doctors that went to the FDA to petition the black box warning that held a lot of people back from using vaginal estrogen because of medically inaccurate information. So get informed. I'm not a doctor, but I know the research, and those are some people you can follow to get informed yourself. But yes, I do believe that it is an essential part of having our vulvovaginal health and our pelvic health aging powerfully with us and allowing us to age powerfully.
Let's dive into. I'm in the good good spot thing, because I've been using it for over a year now, and I just think it's so transformative for myself. I didn't get any symptoms of menopause, to be honest. It's been it's everything I'd hoped and dreamed it would be. When I was a kid, I couldn't win. I'm like, I got a period? What the hell is this? And so for me, menopause has been this exciting time when I don't have a period anymore. But that one piece that GSM was like, oh, really? And my husband was saying, gosh, being a female, it's really tough getting old. And I said, well, hon, because he's 11 years younger than me, your hair loss, your eyesight, your ears, like no one's getting out of this alive. And so it's just another organ, and we're aging, but learning how to take the best care of it. And we're not doing things that are straining as we're aging that particular organ or whatever it is that we're addressing. That's where we want to go. And that's what empowerment's about, right? Knowledge is power. Let's talk about strength training. Because I know the gals listening to this, they want to know, like, but what about, how do I breathe? What's bracing like? What do you mean system? You heard me talking when on Gabriel Lyon's podcast, I mentioned core breathing. It really is reminiscent to me of how we breathe in yoga. We do a fly up block, and we're always stretching the spine up as well. So for me, it was very easy to tap into that. As a coach, I see, Kim, a lot of women. In fact, I had a couple of girls recently just do what were they doing? An advanced bird dog, right? And I wanted to see their midriff, because I want to see what's, I'm looking at what I'm seeing for the vertical body, and then what I'm seeing with the horizontal body. And sure enough, I'm like, yep, that's exactly what I thought was happening. So I'd like to hear more about this part of the pelvic floor being part of the core muscles, how we can shift our approach to posture and to breathing and to bracing, understanding how that system could work, talking about timing and all of that. Can we dive into that and spend a few minutes? Great.
Yeah. When you look at physiologically what happens in the body, when we take a breath in, what happens in that core 4 canister that I was talking about, diaphragm, pelvic floor, transversus, multifidus. When we take a breath in, the diaphragm ideally kind of widens, flattens as the ribs expand out, and that's helping draw, it's changing pressure, it's helping draw air into the body. What ideally happens is the other parts of the system is the belly expands and the pelvic floor expands, and that is allowing air to come into the body. Then when we exhale, so physiologically on the inhale, the pelvic floor lengthens and expands. On the exhale, physiologically, without us having to do it, what should happen is the pelvic floor contracts and lifts, the belly naturally draws inwards, and that diaphragm that was flattened goes back up, and that is now expelling the stale air from our body. That's physiologically what happens. And so when we, back 20 plus years ago, when I was starting this work, working with pregnant women, wanting to teach them how to coordinate the pelvic floor with the breath, we started to use the term core breath, because we wanted to highlight that the pelvic floor is part of the core and that the breath is a really integral part. So that's where the term core breath came from. And and anyway, lots of people use that term now, which is amazing. It's the expansion of the pelvic floor on the inhale. But again, because we can't see it, we need some visualization. So things like, imagine blossoming your vulva. Imagine even blossoming your butt cheeks. Thinking about if you're sitting on a ball that you can feel the movement of your breath into your pelvic floor with. If there's a round ball you're sitting on, if you're straddling over a towel, when you take a breath in, you would almost feel like a sense of fullness on that ball. So that's the inhale. That's the lengthening that's happening in the pelvic floor on the inhale. Then when we exhale, we should feel like that fullness starts to recede a little bit as the pelvic floor lifts, contracts and lifts. When we are retraining somebody, or if we want to bring this into movement, we teach the core breath first. So people understand inhales lengthen, exhales engage, inhale to expand, exhale to engage. We pattern that with visualization, with touch, with different positions of the body. Then we start to add in a voluntary activation. So this is the Kegel part of it. So people interpret Kegels as just a squeeze. Kegels are a voluntary, yes, squeeze, but also lift and then release up the pelvic floor. So we just talked about that's what the core breath is really doing as well. So we add in voluntary activation with cueing, with visualization. So things like imagine picking up a blueberry with your vagina and your anus. So there's
the blueberry.
close.
I was using
Yes.
that with my mom on a story post recently. Now I just yelled at her, "How's your blueberry, Joan? I think your
Yes.
blueberry's on the floor."
Nobody looks at blueberries the same way. But so that is the closure, the squeeze part of, but there's also the lift. We want to lift that blueberry up. And we used blueberry very specifically because most people interpret, if I want to get really strong on my pelvic floor, I have to do the hardest Kegel I've ever. They're thinking about, I need to lift up a piano. We're saying, just pick up a blueberry, put the blueberry back down. And that's, you don't need a huge amount of force. So that's one cue. It could be sip a smoothie through a straw with your vagina. It could be imagine a tampon slipping out. You want to pull it back in. Imagine pulling something deeper into you. There's no best cue. It's which one is best for you and which one elicits the best response. So pattern the core breath. What's happening? Inhale, exhale. We add the voluntary activation on the exhale, the inhale, then blossom your vulva. We pattern that. And now the limiting factor with go home and do your Kegels, when nobody is taught how to do them, they're doing them incorrectly, but also Kegels are taught of go and do 300 of them. And people usually do them sitting at a red light or when they brush their teeth or lying on the ground, which if they're doing it correctly, better than nothing. But if we want to lift heavy, if we want to run, if we want to do yoga, we are moving, we're upright against gravity. So we need to train the pelvic floor dynamically. So once we've patterned the core breath, we've added in the voluntary activation and relaxation with the different cueing. Now we layer it into, we start with like a bridge. We start with a pelvic tilt. We start with squats. Then you can go into more front-loaded push-ups, bird dog. Then we go into standing. Then we go into power, more explosive movement. So we're repatterning the pelvic floor so it knows when to respond, how much force to generate to meet the task at hand, and that it can let go after. Like, I don't mean completely let go, but I mean, it shouldn't always be on. And people think, again, like if I'm just always on, that's going to strengthen my core. But we need this range of motion. We need good blood flow and circulation. So that's kind of the initial pattern. And then we do need to work more on releasing. Let's focus a little bit more there, but we're not going to eliminate the activation. We're just going to maybe focus on releasing tension. If you need to focus more on the up regulation, we're still going to do release work, but we're going to focus a little bit more on the up regulation. If we need to focus more on timing, we're going to make sure we really have that pre-contraction before you move. And then we're going to add some explosive movement in there so that we're always training the pelvic floor to respond appropriately. And then we get to a point where the pelvic floor is ideally automated. We shouldn't have to be thinking all the time, picking up your blueberries or sipping a smoothie. But there's going to be certain activities where maybe we can lift heavier. Maybe we perform better when we do. It shouldn't be, I have to go to my pelvic floor exercise. Now I'm going to go work out. We can combine the two together. It doesn't have to be through your whole workout, but pick a couple of exercises within your workout where you add that core breath, where you're getting the reps in for the pelvic floor. You're taking it through the range of motion. Make sure you do some release work at the end, just like you stretch for your other muscles, and make it part of your workout, whether it's yoga or Pilates or resistance training or whatever it is.
Do you have different cues for women to focus on in terms of bracing for heavy lifts? Like say somebody's going to deadlift 200 pounds, right? You got a 120-pound girl, 200 pounds, in her mid-50s. She's doing the vaginal estrogen. She's not having a lot of leakage problems, but she wants to be able to learn how to breathe properly. Would you invite her to start cueing differently, breathing differently? Because I know that in powerlifting, we're taught to really like fill up the belt, breathe into your lats, and kind of like bear down.
Yes. Yeah. And so in an ideal world with that person, if they didn't have any symptoms, then I might not necessarily change much. I would still teach them the core breath. But if somebody especially is dealing with symptoms, I would have them come and do that protocol that we just said. Then that can happen within a couple of weeks to maybe a month for people to retrain and then gradually progress back. But there are many different ways of breathing. And I don't want to say that there's good and bad breathing. There's different ways to breathe. There's different ways to brace. And it's really going to be dependent on that person, on their pelvic floor, on their symptoms, what they experience in that moment. So inhaling into the belt, and then maybe letting a little bit of the breath out and holding it while you lift is a strategy. There's Valsalva, there's bearing down. And I would say the image of bearing down is what could potentially be challenging in the long term for some people. So we want to make sure that the pelvic floor has the capacity to meet the pressure that is being generated from that lift. Intra-abdominal pressure is normal. Intra-abdominal pressure is something we all experience. We just need to make sure that the foundation we have, the pelvic floor, can meet and manage that pressure. If it can't, if it sends you the signals of farting, peeing, leaking, urgency, pressure, prolapse, then we need to change something. Maybe we need to change the way we do the breath. Maybe we change the time of day we do it. Maybe we change how many sets or reps that we do. But I would always counsel people on the principles of the relationship of the diaphragm and the pelvic floor, train the pelvic floor for capacity, and then progressively load it.
Beautiful. Just get the reps in. And there's a lot of tools, including that consciousness of how you're breathing. And that anyone can do it. I know myself, I've just recently started to incorporate the core breath into like my Romanian deadlifts. And it's interesting. It really changes. It really, it's like I'm learning how to breathe again for powerlifting. Yeah. Because powerlifting, I wanted to have the shortest, thickest waist. I wanted to be the shortest, thickest person in the room. My saying is get tight, stay tight. And my body my waist probably goes from a 26 to a 28 when I'm braced. And a lot of it actually comes from my obliques. My obliques, and my erectors are for my size, big. Right. But now I'm starting to shift a little bit, just trying to trying to be proactive. Number one, as a coach, I want to know if I'm telling someone to do core breathing during a hard, challenging hip hinge, what does it feel like to do that? It's like, oh my God, I got to think about breathing again. And also it's nuanced because you don't want to be, we think of like exhale as you stand back up again, but that can put your back at risk, right? You do need to maintain some pressure against some intra-abdominal pressure enough that you're protecting your spine. So it's nuanced, and it's good to just get those reps in and practice that. I feel as a coach.
Yeah. That's part of the reason why I'm bringing the pelvic floor into it doesn't have to be your entire workout. Cause if you're doing a 10-minute workout, sure, you can bring your pelvic floor the whole time, but most workouts, especially when you're working at a level of what you're working with, are not 10 minutes. They're 45 minutes, an hour. But have a section in there. Maybe it's the priming. Maybe you do your pelvic floor at the beginning. There was an interesting study that looked at Kegel exercises done prior to resistance training as, again, just kind of priming the muscle to respond. Then Kegels combined with resistance training, which is really what's kind of supporting my bias. But those show better improvement compared to just a set of Kegels as like a pelvic floor exercise that routine that you do over here and then you do. Yeah. So get the reps in and keep doing the reps. It's the pelvic floor people view it as, oh, I only have to do pelvic floor exercise now because I have these symptoms. And once the symptoms go away, then I just don't have to do pelvic floor exercise anymore. That's not the case. We need to, just like brushing our teeth, just like we can't, I've developed my biceps and now I competed and I won. Now I don't need to train anymore. No, we need to keep the muscles working. We need to stay strong. To age powerfully doesn't mean we stop doing it once we've reached a certain level. And the pelvic floor is not the same. This is for life, and incorporating it into what we are already doing, or let that be the catalyst that enables us to start doing resistance training. That's why it literally is the foundation. We have to honor and build that foundation.
One other thing I'd like to pick your brain with, since you're the expert on pelvic floor health, is around posture and kind of visual signs and symptoms that you might spot in a woman just based on posture alone, or can you do that?
Mm-hmm. Yeah, posture is a huge one. So, and when we think about in the teaching of the core breath, we always would say ABCs. A for alignment, and your posture will dictate your alignment. Breathing, which was the core breath, and C was coordination. So you have to do the alignment posture first, then you treat your train the breath, then you bring it into movement and coordinate it. So that was kind of the and still is the principles that we follow. So how we hold our skeleton will ultimately dictate the alignment that we have. And when we think, like what I'm talking about from alignment, is that relationship of the diaphragm and the pelvic floor. Okay. So if we are excessively rounded in the shoulders, so hyperkyphosis, that will kind of collapse and change the relationship between how the pelvic floor, how the diaphragm is aligned with the pelvic floor. If we have excessive tension in the side body, in the obliques, that might change how the pressure is distributed. If I am constantly sitting with a tucked under pelvis, if I'm chronically in high heels or shoes that have an elevated heel, there's adaptations that happen that change the position of the pelvis, which will influence or affect that alignment. So to make sure that that core four is working optimally, we want to have the diaphragm over the ribs, over the pelvis. When we have excessive kyphosis, it's going to change that. When we have a tucked under tailbone, it's going to change that. When we had an excessive anterior tilt, it could change that. If we had any even like rotations within the ribs, like I'm getting very specific here, but lots of little things can influence this alignment. So we want to pay attention to what is holding us in non-optimal alignment or posture. A lot of it could be tight calves, tight hamstrings, the footwear that we have, tight pelvic floor, tight glutes, tightness in our obliques, bracing, like chronically holding our abs in, rounding in the upper body, or trying to do the opposite by military posture could also potentially flare the ribs forward as well. So there's lots of little things, but when we understand that principle, the alignment piece, and we look at, oh, well, like I see so often rounding of the upper back and tucking of the pelvis. That is very, 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 very common. I'm not going to say it's the only thing I see, but it's the most common. Oftentimes it is from guarding. I'm afraid of leaking. I'm afraid of urges. I'm afraid of my organs falling out. So I'm going to grip and hold. That's one thing. Also the sitting postures, tightening up the hamstrings, the footwear that we have, shortening the back legs, pulling us into posterior tilt. So when we know that, we can work on lengthening the hamstrings, releasing tension in the pelvic floor, releasing the glutes, changing our footwear, changing how we stand. And over time, just like our body adapted because of the postures we had before to get to this alignment, now when we put different inputs into the system, the body's now going to adapt to bring us back to that better alignment. We can't just say to somebody who's been in that posture or alignment, just like, oh, here's more optimal alignment, now stay there. There's a reason why. There's been adaptations that have happened to create that. So we just need to give them the information and the approaches of how to unravel that so that we now have new inputs coming in, and over time, the better alignment will result.
Are there any like typical cues that you would give to somebody who was in that really rounded? I also find like distension of the abdomen. And I call it non-active glutes. So I see a woman standing, whether she's doing the dishes or waiting in line, and her glutes are completely, they've checked out. I like to say, like, they're having a margarita in Cancun. And I'm like, how are you standing with these powerful muscles completely just flaccid? And then I'll see the lower abdomen distending. And I'll also, as a coach, I'll get a lot of constipation issues and gas and bloating, especially when they hit that menopause. Do you see those things? And is there a cue? Yep. I'm saying stitch the ribs down a lot now, like just because I see a lot of flaring as well as it's just all kinds of, I feel a little bit like I'm playing whack-a-mole. So are there some things that you can cue?
Yeah. So the stitch the ribs down is like ideally the ribs, if we were to find the bottom of the ribs, should ideally be aligned with the top of the pelvis. But again, we have to think of what is causing the ribs to flare in the first place. Is it stretched in the front? Like, do we need to work more on shortening the abs? Is it tightness in the back? Is it tightness in the obliques? Like, we need to figure out why, kind of root cause looking at, rather than just give them the cue to put the ribs down. That will help in that moment, but it's not necessarily addressing what's happening, right? So there's no magic cues, but when I'm working one-on-one with somebody, I will often just have them do a few movements. I have them touch their toes. If they excessively round in the upper back to get down, especially if they also have to bend their knees, that's a good indicator of tightness in the hamstring, tightness in the pelvic floor. If when they do a squat, they kind of have a flat back and their knees are going forward first as opposed to a nice hinge back and sitting backwards in a chair, that's a good indication of tightness in the pelvic floor as well. It's a little self-test that people can do, but I also film them with their permission, usually on their camera, take a picture of how they are standing, take a picture of how they move, video it. I take them through the process, starting with words first. So cueing of lengthening through the top of the head. Sometimes I don't say stitch the ribs, I'll say drop the ribs or soften the ribs. Sometimes I'll say find the pubic joint and the hip bones and put those in the same plane. I'll say blossom the butt cheeks. I'll say vertical legs, depending on how sometimes people are with the posterior tilt, they press their pelvis forward. So backing the pelvis up, tipping the pubic joint forward. So it's really going to be dependent on the person standing in front of me. But then once I've used words to get them in better quote unquote alignment, take another picture, take another video, and then have them relax. And once you've guided somebody into better alignment, they say, this feels like I'm sticking my butt out, or I feel like I'm going to tip over. But when you look at it, it's this beautiful plumb line. And we are very strong and stable when we are stacked. And so often the positions we end up in are actually contributing to joint degeneration and a lot of the pain we have and tension in the muscles because we are out of that optimal stacked alignment. And when people see it in their own body, even though they might feel something different, it's very compelling to them to say, that actually looks really good. And did you see that your abdomen now is not as distended because the pressure isn't trying to, the pressure management system we have when we have this collapsed or flared ribs and the pelvis not in the right position, it can create that distended belly. And now when you align and stack somebody, oftentimes their midsection just naturally looks better, because that is a big, strong motivator for so many people, is what their midsection is doing. And they will often hold it in thinking they're strengthening the core. That's going to help them flatten their midsection, but that could contribute to non-optimal breathing, pelvic floor dysfunction, constipation.
It's like you got to find the right approach. And of course, there's that unique, there's the individuality, like where's the link, what's the broken link, and then what's the right cue that really clicks with that person. I find as a coach, it's when people are in movement that we see things breaking down. So somebody could have a beautiful plank and everything's like aligned and tucked in and all of that. And then as soon as I say Cape Bird Dog, that's when I see the body start, like the abdomen drops, the glutes soften, shoulder blades do their own
things in the moment. Yeah.
Or if they're doing I see it a lot, they're doing a reverse lunge or something, like the glutes. I don't know how they do it, but they're able to do a reverse lunge with really poor activation in their glutes. And of course, then I see the lower abdomen really, it just distends. So I know that whole space of the abdomen, the pelvic floor, and the glutes, they're not connecting. I've actually started to suggest to clients to go, I outsource, right? Because there's only so much I can do online. And so I'll suggest that they see a really great Pilates instructor that uses a reformer to learn how to integrate in movement and motion, great like postural awareness and breath and all of that. I don't know what you think about that. I'm always trying to add things to the stack for my clients.
Yeah, Pilates was one of the first sort of movement practices that really started talking about the pelvic floor before the pelvic floor was cool, before it was
I didn't know that.
Yeah. So a lot of principles in Pilates are great. Back to the person, if they're holding something like a plank, they're fine. But as soon as you start to have the movement, part of it is it's again, the breakdown of that inner core system and the pressure that's now generated because there's extra layers of movement happening. Sometimes people are holding their breath. Sometimes they're trying to create stability. And oftentimes, again, I know I'm biased, but if you come back to training the pelvic floor it all of a sudden allows more control and stability in those movements. But sometimes, like if you see that in a movement, it doesn't mean that that exercise is bad. It doesn't mean that you can't do that exercise. It's meaning like we need to change something about that exercise right now. Let's back it up, retrain the pelvic floor and with the core breath. Now let's layer it. Let's just do one arm at a time. Let's do one leg at a time. Let's do bent arm and leg. Let's do now and progress. Like, you know, the principles of progressive overload, same thing, but it's usually getting the pelvic floor in check transforms how people lift and how they move and how they feel in movement and how they recover, because they have that core stability from where they're generating power from working optimally.
I've gotten so much from this call, and I'm excited to dive in more into what you've got on YouTube and share that with my clients. I just think we're at the cusp of just so much wonderful information that's exciting for women that will really change our trajectory. So vastly different than my poor mom. And of course, anything that I can pass over to her, I'm doing it, right? Because I never think it's never too late, and you don't know what kind of positive impact some of these protocols could have. Kim, last thing, if you could rewrite the message, that women hear about pelvic health and aging, what would it be?
I would make sure that the message is delivered much earlier in life. I would make it part of when we are teaching kids about the menstrual cycle, about sexual health, about our bodies, we should be planting the seed about the pelvic floor and why it is important, why those that are female have additional layers to think about because they have menstrual cycles, because the majority of them will become pregnant, because all of them who reach midlife will go through menopause. It's a part of the body that really deserves a lot of attention, because we can also bring it into the conversation around sexual health. I hope that it doesn't, like right now, sexual health is a lot about avoiding sexually transmitted diseases and pregnancy. It's not talking about pleasure. It's not talking about intimacy. It's not talking about communication. It needs to be brought in. The pelvic health needs to be brought in much earlier in life. So my change would be talking about it earlier and putting it in an empowering way so that people know what is normal, who to go see when it's not normal, but also that they do look at a pelvic floor PT ideally as somebody that's just part of their care team as they get older, once they become sexually active.
Love it. Kim, thank you so much for being on the show. I know you're busy. We've learned an absolute ton. I'm going to share in the show notes all the ways, guys, that you can tap into Kim's knowledge base. She has a YouTube out, a podcast as well, books, a ton of information. She's been at the cutting edge of pelvic floor health for a couple of decades now, and is a really great evidence-based practitioner. Thanks, Kim.
Thank you so much for having me.